So, a man arrives at a psychiatric ward after weeks of confusion, agitation, and behavior his family can no longer recognize. The intake forms list paranoia, mood swings, and disorganized thinking. But during the first evaluation, a psychiatrist notices something unexpected on the side of his neck, a faint, irregular bulge that shouldn't be there. That observation will rewrite the entire case. The patient was a man in his early 40s with no prior psychiatric history. He had worked steadily, maintained relationships, and shown no signs of mental illness until a few months before admission. Then his personality began to shift. He became irritable without clear cause, suspicious of colleagues, and struggled to focus on routine tasks. His sleep fractured. His thoughts seemed to scatter mid-sentence. Family members described him as increasingly unlike himself, volatile in ways they had never seen. When he began to express beliefs that seemed detached from reality, they brought him to an emergency department. The emergency physician, after reviewing his symptoms and behavior, referred him for psychiatric evaluation. He was admitted to an inpatient psychiatric unit under the working impression of a first psychotic episode, possibly schizophrenia or a severe mood disorder with psychotic features. The plan was stabilization, observation, and medication. Over the first few days, the clinical picture remained chaotic. The patient's moods swung unpredictably. He was at times withdrawn, at other times agitated or combative. He reported feeling watched, and his speech was tangential, meaning he would start on one topic and drift without clear connection to another. Initial lab work showed no obvious metabolic cause. His electrolytes, kidney function, and liver enzymes were within normal limits. A urine drug screen came back negative. The psychiatric team began a low dose of an antipsychotic medication, standard practice for acute psychosis of unclear origin. But the medication produced little improvement. If anything, his confusion seemed to deepen. He became more lethargic, harder to engage. His responses in interviews grew slower, less coherent. The attending psychiatrist, trained to think beyond pure psychiatric diagnosis, conducted a detailed physical examination. That is when she saw it, an asymmetric fullness on the right side of his neck, just below the angle of the jaw. It was subtle, not immediately obvious, but once noticed, it demanded explanation. She pressed gently. The area felt firm, possibly nodular. A neck mass in a middle-aged man with new-onset psychiatric symptoms is not a coincidence to ignore. The psychiatrist ordered an urgent imaging study. An ultrasound of the neck revealed a solid mass in the right thyroid lobe. A follow-up computed tomography scan, or CT, confirmed the finding and showed no obvious spread to surrounding lymph nodes. Thyroid function tests, which had not been part of the initial emergency workup, came back abnormal. His thyroid-stimulating hormone, or TSH, was severely suppressed, and his levels of free thyroxine, known as T4, and triiodothyronine, or T3, were dangerously elevated. The diagnosis became clear. He had hyperthyroidism, an overactive thyroid gland producing excess hormone, and the mass suggested a toxic adenoma, or possibly thyroid cancer. Hyperthyroidism affects the entire body. Thyroid hormones regulate metabolism, heart rate, temperature, and importantly, brain function. When levels climb too high, patients can develop what is known as thyroid storm or thyrotoxicosis, a life-threatening condition. But even moderate hyperthyroidism can mimic psychiatric illness. Patients may present with anxiety, agitation, paranoia, mood instability, and in severe cases, psychosis. The term for psychiatric symptoms caused by thyroid dysfunction is thyrotoxic psychosis, and it is rare but well documented in medical literature. The challenge is that these patients often arrive first at psychiatric services, not endocrinology clinics. Their behavior, not their neck, is what brings them to attention. In this man's case, his family had no reason to suspect a thyroid problem. He had no obvious goiter, no tremor severe enough to raise alarm, no heat intolerance they could link to a medical cause. His psychiatric symptoms were the loudest signal, and they nearly obscured the root pathology. Once the thyroid disorder was identified, the treatment plan shifted immediately. The antipsychotic medication was tapered off. He was started on a beta blocker to slow his heart rate and reduce physical symptoms, and an anti-thyroid medication to block further hormone production. Endocrinology was consulted, and a fine needle aspiration biopsy of the thyroid mass was performed to rule out malignancy. The biopsy showed a benign toxic adenoma, a nodule that secretes thyroid hormone independently of normal regulation. Over the following weeks, as his thyroid hormone levels normalized, his mental state began to clear. The paranoia faded. His speech became organized again. His family said he started to sound like himself. He was eventually discharged with a plan for definitive treatment of the adenoma, either radioactive iodine therapy or surgical removal, and close psychiatric follow-up to monitor for any residual symptoms. But no further psychiatric medication was needed. The psychosis had been a symptom, not a primary disease. This case illustrates a critical principle in medicine. Psychiatric symptoms do not always indicate psychiatric disease. Many medical conditions, from infections to autoimmune disorders to metabolic imbalances, can present with confusion, agitation, or psychosis. Thyroid disorders are among the most frequently missed. Guidelines recommend checking thyroid function in any patient with new-onset psychiatric symptoms, especially when there is no prior history, but in the urgency of a crisis, those tests are sometimes deferred. The physical exam, a tool often underused in modern high-tech medicine, remains irreplaceable. A careful clinician's hand on a patient's neck, noticing an asymmetry, changed the trajectory of this man's life. Without that observation, he might have spent months on psychiatric medications that would never address his true illness. The lesson extends beyond this single case. Thyroid dysfunction is one of many reversible medical causes of psychiatric symptoms. Vitamin deficiencies, infections like neurosyphilis, autoimmune encephalitis, and even certain tumors can all masquerade as primary mental illness. That is why a thorough medical workup, including physical examination and appropriate laboratory testing, should precede any psychiatric diagnosis, particularly when symptoms appear suddenly in someone with no prior history. The psychiatrist's willingness to look beyond the intake diagnosis, to perform a full physical examination, even in a psychiatric setting, is what made the difference. It is a reminder that the body and mind are not separate systems, and that the most effective care requires clinicians to see the whole patient, not just the presenting complaint. This video is based on a publicly documented medical case and is intended for education and storytelling only. It is not medical advice. If you are experiencing concerning symptoms, consult a licensed medical professional. The man who arrived confused and combative left the psychiatric ward with a clear diagnosis and a path forward, all because someone looked a little closer and asked why his neck was swollen. Medical mysteries. Every symptom has a story. Every patient deserves to be heard. Medical disclaimer. This video is based on real, publicly documented medical case reports and is intended for educational and storytelling purposes only. It is not medical advice. If you or someone you know is experiencing similar symptoms, please consult a licensed physician immediately.